Hello everybody, welcome to the Rodent Microsurgery and Hemodynamic Training Program. This webinar will cover advanced applications of hemodynamics, pressure and PV loops in vivo preclinical research. My name is Filip Konečný and I'm application scientist and surgical trainer with Transonic Science. Let's move to the first slides. Here we will cover the list of advanced concepts. And I will cover in this webinar pulse wave velocity, PWV. Second, it will be pulmonary artery pressure, PAP, and PAP augmentation index. And third one will be pressure volume loops, and all will be covered by this webinar. Also, I will not cover extensively pulmonary side of pulse wave velocity, and also I will not cover pressure volume on the right side. In the pulse wave velocity, the concepts are similar in aorta and will be covered in the aorta examples. So moving to the third slide, I will see the overview of pulse wave velocity, and I will review the concept without going into mathematical details, concentrating rather on physiology and measurements of pulse wave velocity, its detection and its quantification. Pulse wave velocity is a measure of arterial stiffness. Pulse wave velocity measurements have a strong correlation with the cardiovascular events and morbidity and mortality. Major arteries have viscoelastic properties, and during loading the energy is stored and during unloading is released. So this is considered as a viscous state, while some is returned, which is called the elastic recoil. So the arterial smooth muscle cells are a major vascular viscosity player, and the smooth muscle cells produce extracellular matrix. For example, it's called ECM, and one of the major ECM is called collagen, and it plays a major role during pulse wave velocity propagation. And commonly, extracellular matrix collagen increases during disease states. Pulse wave velocity can be measured in aorta, which is the most common site, and pulmonary artery also. So we had placed resources for pulmonary wave velocity in pulmonary artery on our resource page. In the aortic pulse wave velocity, in the healthy subject, pulse wave velocity increases away from the heart, as in, for example, ascending aorta. Elastin partially decreases. The wave propagation and collagen increases the amount in descending aorta. It speeds up the wave propagation. This is in healthy subjects. When the ascending aorta elastin versus collagen relationship or ratio changes, or during the remodeling, as collagen increases, for example, its presence in ascending aorta or both, on both sides, the pulse wave velocity increases. Other applications are, for example, pulse wave velocity can be used to compare physiologic regional vascular properties in pulmonary artery versus aorta. Moving to the next slide. Here, on the next two slides, I will cover and use recent measurements of pulse wave velocity in dog's aorta. For this measurement, I have selected double pressure catheter with known distance of pressure sensors in between. In this example, you can see the catheter and arrow pointing to both proximal and distal pressure sensor of the catheter. And the catheter, you can notice, it also has a pigtail end. On the next slide is the measurement of aortic pressure from the experiment. On the first row is described measurement using P1, it's a pressure sensor 1. Second row shows P2, aortic pressure 2. Third row describes second derivative of dP/dt of pressure 1. Fourth row is second derivative of P2. To locate the foot of the wave, I have used second derivative of dP/dt from the aortic pressure. So here, the max peak of second derivative of dP/dt of P1 is selected. You can see as a blue circle over the dP/dt on the third channel, and it's also on the fourth channel you can see it selected on the peak of that second derivative. So we see that pulse transit time is time that takes the pressure wave to travel between these two sensors. Pulse wave velocity is then calculated as pulse wave distance, we know that distance, divided PTT, pulse transit time. Okay, so we see that 0.05, it's distance between those two sensors, divided 0.01, which is measured pulse transit time. PWV is then equal 5 meters per second. On the next slide, there are some examples of 3 other techniques that can be used to obtain pulse wave velocity. First option is to use 2 separate pressure sensors, and here we have it in a red example, where distances is measured by imaging technique. Second example is the mouse, using pressure sensor in the abdominal aorta, while USG probe 30 megahertz examines the aortic diameter to run it with the aortic pressure waveform. Please see the link for more details. In the third example, we're talking about the transit time flow probe and the pressure sensor deriving the pulse wave velocity while characterizing the ventricular vascular interaction and also important impedance in the system. On the next slide is the concept number 2 out of selected advanced concept covered by this webinar. Here, pulmonary artery pressure and pulmonary artery augmentation index will be covered. Pulmonary artery augmentation index is the ratio of delta P divided by pulse pressure. That's called augmentation index in the pulmonary artery. Delta P is from the inflection point and from the peak pressure. Moving to the next slide. Here, I will cover, before we get there, really, I will cover the description that I have just inserted in this slide for refreshment of the concept of pressure transition between the major arteries on the right and left sides. First, we see the waveform on the first row of the pulmonary artery pressure, which is on the left, transitioning into RVP, which is on the right. Please note the wave of aortic pressure, which is on the left, transitioning onto LVP, which is on the right in the second row. Finally, we're getting into the augmentation index, which will be in the next slide. The augmentation index is explained on the pulmonary artery pressure wave. Here, PP stands for pulse pressure on the left, that is delineated by the blue arrow starting at EDP, and it's peaking at the pulmonary artery pressure peak, reacting a systolic peak pressure. Please notice that PI, the yellow arrow point, here the PI basically refers to a pulse inflection, where delta P is a change of pressure between inflection point to the systolic pressure. Augmentation index, therefore, is AI equals delta P divided PP. In the next slide, we will cover or briefly touch on the value of pressure and its importance and limitation in cardiovascular research. Here, using pressure-only method is not valid as a gold standard in methodology of measurement of cardiac function. Historically, peak of DPDT used as an indicator of cardiac function. We know about that. DPDT max and min are affected, however, by systolic and diastolic function, heart rate, preload, and afterload. DPDT measurements are sensitive to changes in LV preload. In mouse, for example, it has been shown that the change in LV preload as low as 1 millimeter of mercury can have 18% change in DPDT readings. Detecting the onset of a small change in preload requires extremely stable pressure sensors with resolutions greater than 1 millimeter of mercury. Moving to the next slide, which are references of all concepts covered by all slides which were preceding to this slide. As we're moving forward, we will cover PD loops. We will cover what's called making accurate PD loop measurements. In this slide, we will talk about how to ensure quality of admittance data, evaluating magnitude and phase, which is the muscle contribution signal, we will cover how to perform a baseline scan, which is a very important portion of this webinar. And also we will cover understanding of admittance calibration, also how the catheter location can affect the data quality, and how load-independent measurements are performing the reproducible and reliable IVC occlusions. Here, the first slide, I will go back a little bit and talk about the transition guided by pressure from aorta into LVP. Everybody knows this is important when you do a right carotid insertion of the catheter, that the pressure between the aorta and LVP changes. Note, please, that the drop of the pressure and the end diastole when entering the LV chamber through the RCA, which is the right carotid artery, changes. If LV chamber is entered through the apical stap, the transition is not present. In the PV advanced section, we will talk about understanding phase. There are 4 channels: pressure, volume, phase, and magnitude. When we're deciding what is a good signal to be used in mouse model, we need to ensure the sinusoidal pattern of the waves that is present, as on this slide specifically made to show one signal appreciation, that is signal called number 3 phase. We see that not only the sinusoidal nature, but also the referred values associated with the wave are important. Phase range equals between 2 to 8. Phase amplitude, the wave amplitude, is 3.67 and is highlighted. You can see the recommended lowest is 2 degrees. So in this, we see that phase amplitude 2 degrees, phase range between 2 to 8. Moving to the next slide, which is specifically put to cover and characterize the magnitude channel. To better characterize magnitude channel in mouse LVP, the magnitude is measured in microsiemens in mouse. Its range for mouse ranges between 900 to 2000 microsiemens and is considered good range along with the wave amplitude 200 to 5000 microsiemens. I have put this understanding DPDT on the PV loop, as the DPDT is the first derivative from LVP. I have inserted this slide for you to better understand where the DPDT max and min are located on the PV loop plane. On this slide you can see pressure, volume, phase, magnitude, and DPDT, which is the first derivative of pressure. We can observe on this slide pressure magnitude loop on the right side. Pressure magnitude loop looks good on the right side, and all signal looks more or less sinusoidal. However, you might have noticed when you look more closely that the phase signal is rather high for mouse. As we have talked about on the slide that was before, for mouse, phase signal should be between 2 and 8. That would be the good range of phase. Here on this slide, the phase signal is high. This means that the catheter might be in the direct proximity of the muscle LV wall. On the next slide, I have plotted the final PV loop originated out of this high phase example. As we can see, the phase signal is very valuable to be captured in this entirety, including its range. As we have discussed, the sinusoidal nature of 3 major waves and their need to be finally checked for the phase range and amplitude, and also magnitude, range, and amplitude is very valuable in PV research. In this slide, I will cover how to run good baseline scan. When you start scan for baseline, you observe, which is encircled in yellow, 2 blips on the blue channel, which is called volume channel. On the volume channel, those 2 blips are associated with DPDT max and DPDT min. These blips, as they are associated with DPDT max and DPDT min, are necessary to be captured in order to confirm you perform good baseline scan. So, is this a good baseline scan? What are the signs of good baseline scan? I'll cover here on this example that this is not good baseline scan, and I tell you why it is not. This is like a quiz and importance of understanding that all signals should be sinusoidal. So on the first channel you can see LVP. LVP is not captured very well. There is no sinusoidal pattern very well described. And also you can see that there is a pre-ventricular contractions on the LVP channel. What does it mean? That you have a problem with the first channel, which is the channel of pressure, and when the blips are not associated appropriately with dp/dt max and min, the baseline scan originated out of this signal will be distorted and will not appropriately capture the baseline taken. In the next slide, I'll show you the load-dependent baseline values for LV pressure in mouse and rat. Here, we can see the heart rate in mouse between 470 to 620 is desirable when you're taking the baseline scan. Systolic pressure between 90 to 120 is desirable also. Diastolic pressure between 1 and 6, very important for baseline. Phase between 4 and 8, yes. We basically covered between 2 and 8. 4 and 8 is appropriate also. Magnitude between 1000 and 2000, and ejection fraction between 50 to 70. Those values are typical for animal with isoflurane anesthesia. Okay, so I also put values for the rat on the right-hand side. I will not cover them, but you can use them for your own baseline data. On this slide, we will talk about generating load-independent data. How are we going to obtain the load-independent data? We will use IVC and Fiorina cava occlusion. That will be the critical method for generating transient preload reduction. Important consideration in this research is not to use metal clamps or non-padded forceps, as these can be a source of noise in the PV data trace or can create a signal grounding. Also, it is important not to use a cotton Q-tips in an attempt to occlude IVC non-invasively. This does not provide the required control of the vessel occlusion. Okay, moving forward, how to do a proper IVC occlusion. In rodents, as compared to large animals, in rodents, you please insert the silk suture directly under the IVC, preferably above the liver. You need to pay special attention to the specific location of the suture to be consistent between animals. Please reference these material and methods sections, how you did obtain this occlusion, how did you create this occlusion, when to submit to scientific peer review and final publication. Also, in closed chest surgery, the abdominal cavity needs to be opened. You cannot just put the Q-tip over the abdominal cavity and press on the liver. Also, for open chest, please use chest intracavitary location. See our RAD application note in the PV workbook. And prior to performing the occlusion, control the values of chamber pressure. Stop the rod and ventilator for a couple seconds, and best in the inspiration phase to limit the respiration artifact for 3 to 4 seconds, and then occlude. Alright, let's move to the timing. Please use the same approach for control and diseased animals. The best method is to lift the suture up while using the timing device. Remember to watch for PV loop shift directly on your screen. Also, what is important to do it repetitively. Repetition. Stop the recording and perform offline data analysis on the occlusion. Look for an immediate ramp of chamber's pressure that should be followed by a drop in volume. Please use timing for standardization and redo IVC when chamber pressure comes back to the baseline. Don't redo it 1 second apart. Just wait until everything gets back. Here in this slide, we will cover the transient preload reduction by IVC occlusion. So we see all those channels, but we make notes that the pressure on the first row and the volume on the fourth row are decreasing on the same ramp. Here you see that channel number 2, the ramp is increasing. That's interesting. Why this ramp is increasing? Remember, this trend has to go up, since the catheter located in the LV chamber now is going closer to the muscle wall. Therefore, the range of the phase goes up instantaneously as you're occluding. You can also imagine here the chamber is empty and blood is leaving the chamber and the catheter gets closer to the inner walls. Here we cover the transient preload reduction and we cover the poor example, which might exist. You might enter and you might end up having this example in your research. Here we see on this example that pressure is going down unevenly with the volume channel. So here in the mouse IVC occlusion, this is a poor example. In this case, I will point you to the one major pitfall. When arrhythmias occurs, please don't perform IVC occlusion and rather wait for its full recovery or pressure restitution and then perform RVC occlusion. You cannot use this occlusion and compare it to the non-arrhythmia group occlusions. Moving to the next slide. In this example, IVC occlusion in mouse was done by pushing by Q-tip on the vessel. We have discussed that, and this will not be the best practice for a variety of reasons. Some reasons are, by using Q-tip and its application, you're not able to judge power of the pinch, so to speak, on the vessel. Also, when you observing the screen, for example, and push on the Q-tip, the ramp may not go down on volume channel. Now you start to panic. Why? Then you increase the pinching power and your Q-tip slips out of the linea cava. There are multiple other scenarios, but please, this method is not reliable and repeatable. On the next slide, this is transient preload reduction by IVC occlusion, another poor example. Last in this section is the example when the catheter is whipping in the chamber, so to speak. Mouse is struggling to breathe. Please make sure that your animal is ready for IVC, as this is necessary preconditioning to the good and reliable IVC occlusion. In this example, please wait for mouse to start or improve breathing pattern. For the summary, pulse wave velocity is a valuable measurement for arterial stiffness and overall circulatory health. We have covered this on the arterial side. Second, pulmonary artery pressure and its augmentation index are valuable in assessment of the proximal portion of a pulmonary artery stiffness. Third example, we had covered some PV loop examples. It is important to be patient and ensure quality of stable baseline data, pressure, phase, and magnitude. Catheter location within the ventricle, anesthesia, respiration, body temperature all play a role in achieving stable data. A baseline scan must be performed to ensure real-time volume is calculated accurately